Okay, so we'll proceed with a very interesting talk from a very special guest and speaker, Dr. Shahrad Taheri, a very well-known figure in the world. He was recognized as one of the 2% of the scientists in the world, a graduate of Oxford, London, and Stanford. One of the people that first had the research about the effect of sleeping on obesity, and now he's having another study running about the effect, whether we can reverse diabetes with lifestyle. And this is what he will be talking to us. Thank you very much.
Well, thank you for that introduction, and thank you for the organizers for inviting me to give this talk. So let's talk about type 2 diabetes. So type 2 diabetes is occurring increasingly in younger individuals. And what happens with the disease is that the disease tends to be most severe and rapidly progressive in younger individuals. We know it's the commonest cause of blindness, commonest cause of renal failure, commonest cause of amputations, ulcers, gangrene, chronic neuropathy, impotence in men, premature dementia, premature ischemic heart disease and stroke, increased cancer risk, polypharmacy, personal and societal costs, and is incredibly expensive. So what do we do with diabetes? So we bring our patients in, we start them on a few tablets, and then we keep increasing those tablets. And then in the end, we give them some injectables, and in the end, they end up on insulin. So they end up like this donkey, carrying all these medications and feeling really bad about it. And every time they come and see us, they say, actually, your HbA1c is not good, your blood pressure is not good, your cholesterol is not good, you're not doing your job. We just keep increasing the medications, and this is what we're going to end up with. And in the end, they end up on insulin, and insulin results in weight gain, which makes the situation worse in terms of type 2 diabetes, and insulin also increases cardiovascular risk. What does NICE say about this National Institute of Clinical Excellence in the UK? So it's a progressive long-term condition. So the patient comes through my door and says, you have this for life, and you have to carry this burden for the rest of your life, and here you go. And they also say that education is really good for managing diabetes. So this is a trial that we did between Birmingham and Leicester, where we looked at education. It was a cluster randomized trial, so you can see it involved 31 different primary care centers, and the idea was to deliver education to see whether that's going to make a difference in terms of diabetes outcomes. And if you look at these outcomes, just to cut the story short, nothing is significant. Nothing. Education doesn't work. Because what we do, the education that we provide is very brief, and most of the time the patient is left to manage their own disease. And we don't really continue with our education. So it's not that education is bad, it's just the way we deliver it, and we're not continuous about it. We don't get the outcomes that we want. This was a study we did with primary care. So we had the non-locally enhanced services compared to locally enhanced services. So the locally enhanced services were really good GPs who were trained to manage diabetes really well. GPs in the UK get paid for managing diabetes well. And you can see here, in terms of achieving HbA1c outcomes, only about 50%, even with the best care, were achieving the HbA1c outcomes that you're looking for. And if you look across the rest of the world, anywhere, US, even Switzerland, wherever you look, this is what we're achieving in terms of HbA1c outcomes. So not only we give people a really progressive disease that they're going to have for the rest of their life, but we also treat it very badly, and we just create this misery. So if you do what you've always done, you always get what you've always gotten. And it's because we ignore the underlying pathophysiology that's going on in terms of type 2 diabetes. We forget, and we don't think about the relationship between obesity and diabetes. So you can see as you go up the BMI ladder, this is data from the Nurses' Health Study and also the Juliana Chan study in Hong Kong. You will see that both men and women, as you go up the BMI ladder, the risk of diabetes goes up. So there's a really close relationship between type 2 diabetes and obesity. But BMI is not the only answer. It's where you deposit the fat. So you can see amongst the ethnicities, this is UK. So if you take white Europeans, at a BMI of 30, Arabs are 26.6 is the BMI cut point for increased risk of diabetes. So depending on the ethnicity, different ethnicities based on genetic background deposit fat differently. And one of the early things I learned about deposition of fat was based on one patient. So I had a patient who had severe diabetes, was treated with insulin, had retinopathy, but she had hepatitis B at the same time and had developed cirrhosis. She had a liver transplant, at which point her diabetes completely disappeared. No treatment, nothing. So where you deposit the fat is really important, and that's what I learned. So you've got to look at the pathophysiology. So if you look at the early effects in terms of developing of diabetes, the insulin resistance due to excessive fat deposition in the liver, and after a while the pancreas stops producing insulin as element of beta cell failure that comes across. So based on the patient that I saw and 20 years of weight management and setting up obesity services, the idea was actually, can we actually make life better? So we did 2 studies I'm going to talk about. One is Diadem 2, which is the first study we did. Our study is a bit like Star Wars films, so we go backwards instead of forwards. So we did Diadem 2, which was done in the UK, and Diadem 1 that was done in Qatar. So this is Diadem 2. So Diadem 2 were people treated with insulin, so they were much older. So if you look at the age is about 58.5, and the HbA1c you can see is about 8.7 to 9.3 in the groups, and they were taking insulin. I was taking insulin for 4 years, and the duration of diabetes about 12 to 13 years. So can we make the lives of these people better? And what we did was we put them on a low-energy diet. I will talk a little bit about that more detail in Diadem 1. You can see weight loss occurred very nicely in the first 6 months. After that, we were not following them up as much, so there was some weight regain. The HbA1c was much lower amongst these individuals. But the headline here is that the insulin dose came down, and 39.4% stopped taking insulin, and their quality of life improved. So we've managed to take these individuals who are taking insulin, multiple injections of insulin, and really improved their quality of life and got them off insulin. So it was possible to do that. So next question is, can we go earlier? Can we actually stop diabetes, reversing diabetes in terms of putting it into remission? So this was, the setup was in Qatar. We talked about Dubai. Qatar's got the same problems, high prevalence of obesity, prevalence of diabetes about 17, 18%. But it's also very multicultural and multi-ethnic like Dubai and UAE is. And that allows us to be more generalized in terms of what findings that we find. High prevalence of obesity and diabetes. So initially we did a systematic review. What's been done in the region to look at weight management as well as treating diabetes with diet and lifestyle. There was hardly anything that was coming out of the region. So this is a call to the region to do more clinical trials to address really pressing issues that are happening here. Because only through clinical trials can we see what works in the region and what doesn't work. We had to learn from what's been done before. So we had to learn from bariatric surgery. So as you know, bariatric surgery is very effective in terms of achieving good weight loss and resulting in diabetes remission, as seen in the Swedish obese study. So what did we learn? Weight loss is a key component. We need to reduce the excess adiposity, particularly in the fat and the pancreas. It has to be rapid within the first 3 to 6 months. And also it has to be young age, early disease, better control to start with, fewer medication, and not taking insulin. So we need to tailor that intervention to individuals who are within these criteria. We also had to learn about the delivery of the intervention. So we learned from the diabetes prevention study and the look ahead study. So those who attended appointment were more appointments were more likely to succeed. Those who managed to adhere to energy restriction, meal replacements were also a good outcome, increased physical activity and early weight loss. In fact, early weight loss is a good predictor in the look ahead in terms of maintaining that weight loss. So this was the people who went to the Diadem 1 study that had to be younger, so 18 to 50 years old, that have early type 2 diabetes within 3 years of diagnosis. And the idea was, can we put them into an intensive lifestyle intervention compared to the best medical care, and with a new philosophy of early weight loss, physical activity, and in the primary care and community setting where most of these people are found. So how does it work? So in the first 12 weeks, they go on a total diet replacement, which is about 800 calories, and it's really difficult to do. People will challenge me on that, so it's really difficult to do. But actually, people did it. And then they go through the next 12 weeks of partial meal replacement, where meals are introduced, and then they go into their own food. And this was very closely supervised in terms of when they went onto their own food, they went to a low GI Mediterranean style type of food. Additionally, they saw a physician, they saw a dietitian, and a trainer who provided them with advice in terms of non-supervised physical activity. And the whole point of this was to, the idea is not to just weight loss, but actually retrain individuals in terms of their behaviors, what they're eating and what they're doing in terms of their physical activity. So it was much more than a diet. Had a really comprehensive behavior change program that was part of it. And the idea was to actually get people not only to achieve weight loss outcomes, but actually to change their general well-being. And we set the remission of HbA1c as less than 6.5% for at least 3 months off medication. This is now the current consensus guidelines, following exactly what we said in the Diadem-1 study. Just to show you, if you look at the top number of countries, people came from 13 different countries. And there were 147 participants. This is unlike any other weight management program, and it's a reflection of the population of Qatar. About 70% were men. You can see that also down here, about 69% were taking more than 3 medications, 3 or more medications, and they were employed as well. So they could, even with that employment, they were able to attend all the sessions that were put for them. There were very few complications because they were early diabetes. So we caught them really early, and the idea is to eventually link this kind of approach to a screening program. And this was published in the Lancet Diabetes and Endocrinology. So you can see good weight loss was achieved in the red in the intervention group that was maintained at 12 months. Okay, it was maintained. Okay, it wasn't like your usual thing, to stop everything and the weight regain occurs. That's not true. It's maintained after 12 months. You can see the fat mass also coming down. I can tell you there was no change in muscle mass. So there was no loss of muscle within this grouping, and we believe that it was the physical activity component that contributed to that. There was no difference in the weight loss whether you were male or female. So there's no difference in terms of the outcomes in the intervention, or whether you came from Middle East or North Africa. So this kind of approach works whether you're male, female, wherever you come from. And if I were to be presenting a drug here, you would be congratulating me that 1 in 5 are achieving more than 15% weight loss, and you come and buy my drug tomorrow. So you can see you're achieving very excellent weight loss. You got 34% achieving more than 10% weight loss in the intervention group. And this is what happened to HbA1c. HbA1c improved in both groups, but the control group were being given medication. Now we can really hands-on in terms of they were using GLP-1s in terms of helping them with their weight and controlling their blood sugars. So just the best diabetes care that you could get. You can see the HbA1c is much better in the intervention group compared to the control group. But the remarkable outcome was a 61% achieved diabetes remission based on our outcomes, primary outcome, and 33%, 1 in 3, had normal glycemia. Okay, this is like no sugar problem at all. And this is an intention to treat analysis. So if you look at completers, 80% achieved diabetes remission, 50% achieved normal glycemia. This is just because we did an intention to treat analysis. This is what we found. Some of the control group also achieved, because they were still being exposed to similar kind of approach. We were giving them really good support. So we did continuous glucose monitoring in these individuals across 7 days. So this is a control group. You can see the green area is normal. You can see the sugars are out of control. And again, the same thing in the intervention group. But at 3 months, you can see this continuing in the control group. But what happened to the intervention group? What happened to those sugars? And let's follow it up at 12 months. You can see still with best medications, the control group are getting variable blood sugars, but this is what happens in the intervention group. So you can achieve really good glycemic outcomes and put diabetes into remission and put people into normal glycemia with a good lifestyle approach. One of the factors that was involved was liver fat. So you can see in the intervention group, liver fat reduction occurred in the first 3 months and has continued. This is measured using a FibroScan. So liver fat reduction, like my patient told me, who came to my clinic with liver cirrhosis, and actually the liver is a very key player. So liver fat was very important in terms of achieving those outcomes. What about adverse events? You can see no serious adverse events in the intervention group compared to the control group. And of course, when people are changing their diet, they will have gastrointestinal effects, they will feel dizzy, increased dizziness. And because they were coming more often, they were reporting more colds and coughs and things like that. How does it compare to other studies? So you must be aware of the direct study. So direct study was carried out in the UK, so they're about a decade older than the population that we see in the region in terms of early type 2 diabetes. And Early Acted was another study that I collaborated with in Bristol. You can see they're much older. They were newly diagnosed diabetes. And in terms of look ahead, even much older with later diabetes on scale, again, a decade older than the individuals that we had. But what about the weight loss outcomes or weight reduction outcomes, as I prefer to say it? You can see the diadem intervention achieved the most weight loss. Here's scale, pre-diabetes, scale diabetes. You can see people with diabetes actually find it much more difficult to lose weight than the individuals without diabetes and obesity. So you can see good outcomes. And if this were a drug or a pill, you would be the first one to prescribe it. What we did was we teamed up with the direct team and we looked at proteomic panels in terms of what the proteomic panels can also predict outcomes. So we used 7,000 proteins that we measured in these individuals. You can see that with the intervention in green, there was improvement in glucose tolerance. Liver fat was reduced based on proteomic panels. Body fat percentage was down, visceral fat was down, VO2 max was up. So the actual, in terms of physical fitness, was improved based on proteomic levels. But the headline here was in the cardiovascular disease. There was a 50% reduction on cardiovascular risk based on a proteomic panel. But you can say, okay, this is a panel and it's a predictive. So we need to go back and look at why this was the case. So in terms of hypertension, you can see 71% achieved normal tension. That was off medications and blood pressure within the range, compared to 49% in the usual medical care. Obesity is an inflammatory disease, so with the intervention there was a reduction in white cell count, there was a reduction in CRP, so there was less inflammation going on. So these individuals were much better off and they were much happier. So we need to look at the look-ahead study. So the look-ahead study was much older, much more advanced diabetes, so they achieved very, very little remission with a lifestyle intervention of about 10%. But you can see that the ones, in terms of the prevalence of any remission, you can see that more people in the intervention arm were involved lifestyle achieved a remission status. But the key headline for the look ahead is that actually the ones who had more visits in remission achieved less chronic kidney disease and less cardiovascular disease. So spending more time in remission is a predictor, a little bit like the metabolic memory that we've seen with the UKPDS and other studies, it reduces cardiovascular risk down the line. And we've shown it with proteomic panels. So any time you spend in remission is a good thing. I won't bore you with this, but we did a qualitative study. But I just want to point to you that some of the people, we looked at both intervention and control. We talked to them. Some of them were achieving 38.6% weight loss. So it's very individual in terms of weight loss that is achieved in these studies. But what did we learn from them? when we started doing the study, everyone said, look, you're doing it in an Arab country, nobody wants to do it, it's really hard to do, but actually, what I was learning when I started setting up the obesity service, the first in Qatar, was actually Arab people are amazing. When they make up their mind about doing something, they will do it. So if they buy into it, they will do it. And that's what I found was really amazing, that actually you could get people to actually undertake such a lifestyle intervention. So what do we learn about the factors that are involved? One is there had to be a paradigm shift in terms of understanding what it takes to have a healthy lifestyle. And there was a lot of education that needed to go into that in terms of changing people's views about what a healthy lifestyle meant, and getting them to focus on their health and adapt their lives to how they wanted to do. And in fact, many people found that improving their lifestyle allowed them to succeed in other aspects of their life. One of them developed his own business and was running things, and made them think a little bit more about their life. And we weren't sure whether this was a serious adverse event or an adverse event, because some of the men were saying, can I have a second wife? Now, depending which aspect you look at it, is a serious adverse event or an adverse event. We couldn't record it like that. Support and sharing was important, the social support. There are many sort of factors in the environment and people around us who influence us. People say, oh, you've lost weight, you look sick, you're not well, what's wrong with you, eat more. So it's really important to be able to manage those, so that people need to be accepted for the new lifestyle that they have. And they also learned about observing others and learning from that. They developed a lot of behavioral autonomy, and they kept the eye on the prize. I want to get rid of this diabetes. My father had diabetes. My father had amputations, chronic kidney disease, was on dialysis. I do not want a life like that for me. I want a life that's different, and I'm going to go in that direction. And the motivation is very important. Freedom from disease. I do not want this disease. And of course, responsibilities. Many stated that because I'm a father or a mother, I need to take responsibility for what I do. But don't just listen to me, just hear from the person.
I can't forget when I go any clothes shop to ask about anything, and they told me, sorry, we haven't your size. It's a very difficult sentence to hear. Yes. I feel I'm still young. This is very bad disease. Around you.
I used to be 138 kilos, and now I am 118 kilos, which is make me feel better.
He's 80 kilos now, by the way.
باش ندخلوا resistance training باش نوصلوا يستعملوا على الماشينز هذم.
I can walk, I can run, I can ride bicycles. I feel me good. I feel me better. Yes, difficult journey, but it's the best journey I make it in my life.
You can see how transforming this is for people. To be free of this burden of coming through our door and saying you have this lifelong disease that we have to really put you on medication. You're going to end up like your mother or father with complications. So diabetes remission is a reality. The question how you achieve it, whether it's through lifestyle intervention, medication or surgery, we need to really take it more seriously and allow people to be able to achieve as much normality as we can by addressing the underlying disorder and rethink about type 2 diabetes as a lifelong disease. But we need to achieve it as early as possible. So linking this to a screening program achieves better outcome, but also it needs to be a more comprehensive plan. It can't be just that you achieve that remission and you leave people alone, because they need continuous follow-up to be able to achieve the outcomes that you want. I want to thank all the funders who have supported me over the years. This is one of my researchers who's worked very hard. There's a whole group of people who've contributed to my work, and I'm grateful for their support. Thank you for listening.
Thank you very much, Shahrad, for an amazing talk, as always. Professor Donna Ryan is on you.
Yes, Shahrad, thank you so much. That was a wonderful talk, and congratulations on your 12-month results. You know, the real issue, though, is over the long term. So I have sort of a two-part question. You know, one thing that's been shown with meal replacements is that replacing just one meal a day is effective in weight loss maintenance over the long term. And the other is medications for long-term weight maintenance. So, you know, in Look Ahead, we showed that for people on metformin who are on at least 1,750 milligrams a day, they sustained weight loss, sustained it for 10 years. So what are your strategies after 12 months with these patients? Are you replacing any meals, and are you using any medications for weight loss maintenance?
So what happened is actually the majority went on metformin. So we're now doing the 2-year follow-up because we felt that still we're in the pre-diabetes range. There's very good data that metformin is very effective in terms of maintaining that. You're right.
What about meal replacement? One meal a
well,
day?
the issue was the study was designed as a 2-year study, so we don't have the funding to carry on with the meal replacement, but we certainly carried on with medication.
Yeah, thank you.
Dr. Ahmed Hassoun.
Thank you very much. Excellent study. I have a question about the fat. You mentioned the liver fat was reduced. Have you looked into the markers of fibrosis?
Yeah, we have. We're just looking at the data now. So the markers of fibrosis also went down.
Thank you.
Dr. Shaza.
Hello, thank you for the study. I just wanted to ask, you know, the early finding from the NHS type 2 diabetes remission data has come out recently, and that showed that although 7,500 has been referred, only less than 1,950 have completed the program, and the other just drop, either don't take the referral or don't carry on. Have you finding similar thing on Qatar, or your patient more motivated to do it by themselves without actually having you to try to make them go for the program? Because that's more than 1/3, well, no, 6,000, well, 7,000 to 1,000, so almost the majority of the patients have not actually taken the program for various reasons.
Yeah, the problem with the National Health Service in the UK, because I work there, is that they want everything to be very cheap and cheerful. And managing obesity and type 2 diabetes remission is not cheap and cheerful. It needs continuous effort. And what they did was they gave it to different companies to do. And there wasn't a very structured behavioral program that went with this. So you need to have a really good program and engage people on a personal level to be able to get them into the program. And many people, the belief also outside is actually it's the individual's fault. And if they have any weight problems and things like that. So not many people get referred into the service. And the ones who get referred into the service, they get a telephone call or they see somebody very occasionally that doesn't give the outcome that you want. If you study 50% of the time, you're not going to get an A grade. You need to study 100% of the time to get an A grade, and that's when you get the outcomes that you want. So you need effort, but even with medication, the outcomes that you will get with bariatric surgery, whatever it is dependent on the care that you provide afterwards and at the same time. And unfortunately, if you go for cheap options, you're not going to get that.
Last question, Dr. Farhana.
Thank you, Doctor. I was wondering, is it about time that we revise remission criteria for diabetes?
Is it time that we tell people? Yes, we should.
I mean, no, revise it, because remission is off medication, so I'm just thinking, would it be revised onset? Because, you know, we have GLP-1s, some of them are taking them if they're, you know, their HbA1c's are under control, they've achieved the weight loss, and maybe they're not taking it as often as they should or not frequently. So I was just wondering, is this about time to revise the remission criteria?
Yeah, absolutely. I mean, I think you have to look at different types of remissions. So there's remission with surgery, there's remission with medications, and there's remission with pure remission. This is pure remission. But there will be people who will be on GLP-1s. The problem with the GLP-1s and the nutrient-sensing hormone-based therapies is that they do have a glycemic effect. So it's very hard to stop people's medication, but we also don't reverse surgery to say that you're off surgery. So I agree, it's a matter of debate.
Thank you very much.